Hello, let's begin our long-awaited series on gastrointestinal pathology. We will cover the major topics involving gastrointestinal pathology, beginning with today's lecture, which is about stomach pathology. Then we will move on to intestinal pathology, and we will end with appendix pathology. And what is in common between these three different pathologies, stomach pathology, intestinal pathology, and appendix pathology, is that the lesions and the disorders involved in these pathologies are either one of two kinds: inflammatory lesions or neoplastic lesions. So when we're dealing with stomach pathology, rest assured that the pathology either falls into the category of inflammatory lesion or neoplastic lesion. Intestinal pathology, it's either an inflammatory pathology involving inflammation or a neoplastic pathology involving a neoplasm, a tumor or polyp. Moving down to the appendix, the issue will either be involving an inflammatory lesion, or a neoplastic lesion or a tumor. So let's today begin with our stomach pathology. And in the stomach pathology, as we said, there's an inflammatory component and there's also a neoplastic component. Today we will talk about the inflammatory component, and that is gastritis. Today we will talk about gastritis and gastropathy, ending with, we will allude to chronic gastritis, and we will move on later to the complications of chronic gastritis. That's the first thing. The second thing that we need to know is that in order to understand gastric pathology, we have to have some rudimentary knowledge of the structure, the anatomy of the stomach. And that will make it very easy for us to understand how the problem of the inflammatory lesion causing this disease, gastritis. And as it ends with itis, it's an inflammation. So an inflammation of the stomach. And every inflammation is either acute or chronic. Okay, so what you need to know is that if there, for example, there's an electric wire. If you touch that electric wire and it is not wrapped in that electric tape, it will electrify you. So with the same logic, our stomach is full of hydrolytic, peptic enzymes in order to digest the food. Carbohydrates, cleave them, break them apart. These fats, break them into fatty acids. Also, these peptic enzymes that break apart the proteins into various amino acids. In addition to, the stomach is just known for being a pool of acid. It is very acidic. The content of the acid in the stomach is 1,000,000 times more acidic than the blood. So it's very acidic in order to break down this food bolus that we take into our stomach. And also, we must understand that this very digestive hydrolytic environment, if it's strong enough to digest a piece of steak or a piece of chicken, what's stronger, steak or our stomach? So why doesn't this acid environment, this hydrolytic environment, why doesn't it digest the stomach itself, just as it would digest steak that we would eat? And the reason is because the stomach is painted with a mucus layer. There is a mucus layer that neutralizes this acid. It prevents the acid to touch the stomach epithelium. It prevents it from touching the layer of the stomach. So you have this pool of acid that is contained in the stomach, but the stomach is not in direct touch with that acid. What is in touch with that acid is that mucous membrane. That mucous membrane is secreted by foveolar cells in the mucus layer. So the mucus layer is itself generated by mucin secreting cells called foveolar cells, and that is the mucosa. And this mucosa is the line of defense that protects the stomach itself from being auto-digested or harmed by this content that it harbors. So in order to have gastritis or to have a stomach pathology, there must be a defect that causes an injury in that mucosal layer that protects the stomach. Am I on? Yes, I am still on. So, you must understand very well that this stomach actively generates that mucus layer and also actively maintains it from disintegrating or falling apart, because if it disappears, then acid is immediately going to start injuring and harming that integrity of, harming the epithelial integrity of that stomach. Okay, another very important thing you must know. There is like a tug of war, or maybe a seesaw. There are two factions. There are factors that try to overwhelm the defense mechanism. You have defense mechanisms of the stomach that maintain the integrity of the stomach epithelium by nurturing and protecting that mucus layer. And you have the acidity component, where if the acidity goes really high, it can overwhelm that mucus layer. You also have bicarbonate ions that neutralize this acid. You have cells in the stomach, in the gastric, the gastric cells, that if in case an acid, a hydrogen proton leaks from the core of the stomach into the stomach epithelium, it will literally take that hydrogen proton and throw it back. If something happens to these cells that throw back the hydrogen protons, then surely we will have damage to our mucosa. Okay, what if there is another problem related to an inability or a defect that disables the mucosa from being able to stimulate these foveolar cells to secrete that mucin, that mucus. So if there is a decrease in the mucus, then who will win? The acid will win, and it will cause an injury. So today we will talk about what causes these injuries. But you must have in mind, we have two things fighting apart. Two things fighting. You have the acid trying to injure and harm the stomach, and you have protective defense mechanisms. We will talk about these defense mechanisms, and we will talk about these offensive mechanisms, and we will talk about what can empower these offensive mechanisms that would cause an ulcer, that would cause gastritis, and what are the things that may weaken our defense mechanisms, like the ability to secrete that mucin, that mucous membrane that protects the inside of the core of the stomach. Those cells also that secrete bicarbonate, those gastric cells that throw back that hydrogen proton that leaks into the inside of the stomach. So we will talk about today will be about that tug of war. How does the injury develop? In order for injury to develop, we have to empower the offensive, the harmful agents, and we have to weaken the defense mechanisms. So let's talk about the offensive agents, and let's talk about the defense mechanisms, and let's talk about how both of them will interact in a way that harms our stomach and cause for us this pathology known as gastritis. So let's begin. Okay, I already talked about how in the stomach our pathologies can be categorized or classified into two different factions. Our disease is either originates from an inflammatory lesion or originates from a neoplastic lesion. In the intestine, we have the same thing. Either a disease originating from an inflammatory lesion or a disease that could be traced back into being caused by a neoplastic lesion. In the appendix, we can also have our disease being traced back into being an inflammatory lesion or a neoplastic lesion. So today we will talk about this part right here, the inflammatory lesions causing a stomach pathology. We're not even going to talk about neoplastic lesions. We'll talk about that the next time. So now let's look at this diagram. We have a bottom layer, this yellow layer, and we have this black layer, that black band. And let me see if I can bring my pointer. Okay. I'm sorry, no marker for today, no pointer for today. So this is the submucosa, this yellow band, and then you have the muscularis mucosa. This is not important for now. This yellow and that black layer. What's important is up here. We have this blue layer and we have these foveolar cells. These are the cells that secrete that green stuff. So the green layer is the mucus layer that protects us from that content. So this here, right here, is an acid and full of acid and peptic enzymes. And this is the mucus layer, like an electric tape that tapes the core of the stomach, protecting the stomach from that acid that's inside it. Okay? And we have this mucosa right here, this blue layer. So what happens is a defect ensues that causes what? That causes disappearance of this green layer. So up to here we have an intact mucosa layer. But if we move to this part, we see that that green stuff starts to diminish. It starts to diminish, starts to decrease. Once there is a decrease in the mucus of the mucus layer, that leaves these cells that used to be protected by that mucous membrane will be very vulnerable for damage. So this is how the damage happens. Then, as we will see here, there will be a damage where it can go so deep from the from the mucous layer down into the mucosa, causing for us necrotic debris and we may see inflammatory cells, granulation tissue, and we would see also bands of fibrosis, scarring tissue. This is very important. Look at the development. We had an intact core of our stomach where that mucus layer is, the integrity of the mucus layer is excellent. And now that integrity falls. So this is what happens. This is what happens in all of the different situations. The cause may be different. We may have a microbe, a pathogen, okay, Helicobacter pylori. We may have a chemotherapeutic agent in radiation therapy. We may have someone who takes NSAIDs, okay? These things may cause the damage, but the cause may be different, but the mechanism is pretty universal. We would go from an intact layer of mucosa to a diminished layer of mucosa to a fully exposed layer of mucosa that will be overwhelmed by the acid and the peptic enzymes, leading to an entire ulceration and a damage of the integrity of the epithelium of our stomach, causing for us different kinds of disease that we will talk about later. So this is very important to understand for now. And also, I want us to know a very important point, and that is we develop from acute gastritis into chronic gastritis into complications of chronic gastritis. So first of all, there is no complications of acute gastritis. The complications are usually caused by chronic. They are complications of chronic gastritis, no complications of acute gastritis. Okay, well then, what is gastropathy? Gastropathy is a mysterious clinical morphology where there is edema, there is congestion, and there is no inflammatory cells. There are no lymphocytes, there are no neutrophils. So can we call that inflammation? No, we cannot. So in order to call an inflammation gastritis, there must be inflammatory infiltrate. There must be inflammatory cells like neutrophils and lymphocytes. But they discovered there is a form of disease where there is a hyperplasia. Hyperplasia indicating there is an adaptive mechanism taking place in the mucosa of the stomach. There will be a hyperplasia of the foveolar cells of the stomach. They also noticed there is edema and there is congestion of blood vessels, but there is no inflammatory content, no inflammatory cells, no neutrophils, no lymphocytes, so they can never call that inflammation because there is no leukocytes and no lymphocytes. So they call that gastropathy. But if you have, in addition to gastropathy, if you have in the histology, you end up realizing there is leukocytes and lymphocytes, then originally that's acute gastritis. If you see the intensity of the inflammation is more severe and lasted for a longer time, then that is chronic gastritis. So gastropathy, they have also realized that gastropathy isn't an active inflammation, obviously. Otherwise, there would be inflammatory content. There would be leukocytes and there would be lymphocytes. So then, if it is not an active damage of the epithelium of our stomach, then what caused it? It is usually caused by pathologies that ensued as a consequence of another disease, like someone who may have liver cirrhosis. Liver cirrhosis led to increased portal hypertension. The increased portal hypertension led to gastropathy. Also, taking alcohol or if there is a duodenal reflux, or if there is a disruption of the gastric blood flow, that would lead to gastropathy. Then if things get out of hand, inflammatory cells would be recruited to the site of the inflammation, and we would develop into acute gastritis, and then we would move on to a chronic gastritis, and we would end up, if not remedied properly, we would have complications of chronic gastritis, which are mucosal erosion, ulceration, and hematemesis, melena, and massive blood loss in very severe cases. Okay, what I want to end up with now is a very important phenomenon, and that is the tug of war or the seesaw that I alluded to earlier. And that is, we have positive, I put them in positive because they are our defense mechanisms. So I put them positive. And I put those in negative because they are our offense mechanisms. Okay, the defense mechanisms are, first of all, the mucin secreted by those alveolar cells, giving us a mucus layer, protective mucus layer. Also bicarbonate that is secreted by the surface epithelium. Why is bicarbonate important? Because bicarbonate neutralizes acid. So that mucus layer must be rich and full of bicarbonate in order for it to counter and resist that force of acidity in the content of the stomach. Also, we have gastric mucosa pumps. Remember, I alluded to pumps that literally take any hydrogen protons that leak into the gastric mucosa and throw it back into that pool of acid in the core of our stomach. And then we have the ability to generate prostaglandin. And this is very important because prostaglandin positively feedbacks and participates in all of these activities. By the way, there's also blood flow to the mucosa. That's why if there's an ischemia to the tissues of our of the epithelium of our stomach, then there will be no mucus layer because the cells that secreted have died in the ischemia. So our cells in the stomach, they need proper blood flow. They need oxygen. They need the blood to come and provide oxygen. We must have no hypoxia, and we need the blood to come in to flush and take away all of the toxic metabolites of our tissue in the stomach, our epithelium, and we need the blood to provide us with the proper nutrition, glucose, and so on to generate our energy. And prostaglandin positively promotes all of the former four defense mechanisms. Prostaglandin promotes proper blood flow of the mucosa to the mucosa, and prostaglandin promotes gastric mucosal pumps that throw back this hydrogen proton into the stomach, preventing an increase in the acidity of the epithelium of our stomach mucosa. And prostaglandin also positively promotes the bicarbonate secretion by surface epithelium, and prostaglandin also positively feedback to promote the mucin secretion by foveolar cells, and this process of generating a mucus layer that neutralizes and isolates our stomach and protects it from and separates between that hydrolytic, that destructive acid from being from digesting and harming our own stomachs as it would to a piece of steak, for example. Now, who is doing the evil work? Who is trying to cause the pathology? It's the gastric acidity, that acid content, that hydrogen proton content. If it increases way above the threshold being tolerable by that gastric mucosa, it will penetrate into the gastric mucosa and damage the gastric mucosa, causing an ulcer. And we will talk about what factors that cause that. And then there are peptic enzymes on the loose that may enter the stomach and cause that damage to our stomach, leading to gastritis, the inflammation of the gastric tissue in our stomach. Now let's talk about prostaglandin. Prostaglandin positively promotes 4 defensive mechanisms, but it causes one negative thing that I put it in red. It's not really negative, but we perceive it as negative. And that is prostaglandin is important for pain generation in inflammation. As we know that in inflammation, there is redness, rubor, there is heat, calor, there is pain, dolor, there is loss of function, functiolasa, and there is also swelling tumor. So that bradykinin that causes an irritation to the nerve endings, leading to that pain sensation during inflammation, is mainly caused by prostaglandin. So whenever we have an inflammation and we take NSAIDs, NSAIDs are non-steroidal anti-inflammatory drugs. NSAIDs drugs. What do? They block a very important enzyme called cyclooxygenase. There's 2 types, cyclooxygenase 1 and cyclooxygenase 2. Like aspirin blocks that COX-1, in addition to naproxen. Aspirin, naproxen, and ibuprofen. These are blockers of COX-1, while COX-2 is inhibited by a drug known as celecoxib. So if we take these drugs, in order for them to block prostaglandin and inactivate prostaglandins, and when we inactivate prostaglandins, we end up inactivating the pain sensation, and we no longer feel pain. But what do we also not have? We're gonna because when we inactivate prostaglandin, we're gonna inactivate everything that prostaglandin does. And one of the things are that pain sensation. But what else does it do? Prostaglandins promote mucin secretion and the creation of that mucus layer that protects our stomach. So now it will be vulnerable to injury causing ulcers. And prostaglandins also promote bicarbonate secretion. So there will be a defect in these ions and inactivity. And there would also be a decrease in blood flow to those cells that participate in the mucus secretion process in our stomach. And there also would be a defect in the regenerative capacity of our epithelium. So we would end up pretty much inactivating 4 defense mechanisms just to avoid that one role of pain sensation during the inflammation. So these are the 4 factors that you need to be concerned with at all times. That during gastritis, what is the defect that unfolded. Pretty much the mucin secretion has been affected, so that green layer started to diminish. The bicarbonate secretion has been attenuated, so that means the acidity will go up, and it will overwhelm the mucous layer, and the blood flow, any factor affecting blood flow, like for example hypoxia, people who go in high altitudes and there is less oxygen, and sometimes in traumas where there is shock and there is not enough perfusion and not enough oxygen, the stomach will be affected and it will not be able to generate mucus and empower that mucus layer of our stomach, leading to a weakened mucus layer, and that will make it vulnerable for ulcer or gastritis. And someone who's really old and these telomeres are not working properly, so their regenerative capacity will be weakened, so that will make them vulnerable for gastritis or an injury to the mucosa of the stomach. And what counters the mucin secretion are the NSAIDs, or being a person of an old age where your cells are not working as efficiently these foveolar cells are not working efficiently to secrete that mucus layer, and bicarbonate secretion will be affected by uremia. Someone who's suffering from uremia, meaning they would have high content of ammonia, and that ammonia will lead to an increase in the acidity, and that ammonia will inactivate the bicarbonate channels, leading to an increase in the acidity. And also an infection by H. pylori, Helicobacter pylori. That bacteria has an enzyme called urease that leads to the generation of ammonia, and ammonia, as I said, will block bicarbonate channels from secreting bicarbonate, and bicarbonate is what neutralizes the acid. So that means acid will no longer be neutralized because there is no bicarbonate, and that is caused by an overwhelming increase in ammonia content, and that is caused by a person who's suffering from uremia, or someone who has an H. pylori infection, and that enzyme is just generating for us so much ammonia that leads to an increase in acidity. So also blood flow, we need no ischemia, and we need proper perfusion of oxygen. Any defect like shock, like hypovolemic shock or any septic shock or any shock that causes a disruption in the perfusion of oxygen supply to our stomach, would cause a defect in the generation of that very important protective mucus layer. And also alcohol and NSAIDs, radiation in chemotherapy. That radiation targets DNA synthesis and mitotic apparatus generation. So if there is no DNA, if there is a defect in the DNA, that would cause a failure in the regenerative capacity caused by the radiation chemotherapy targeting DNA and targeting the mitotic spindle, and that would damage the cells and damage their regenerative capacity, and that would ultimately harm the integrity of the epithelium. Okay, so pretty much this will be a first step for us. I'm very sorry I'm sweating too much because I turned off the AC and the fan so it doesn't interfere with the voice of the microphone. But I hope that this lecture gave us a very important first step into understanding how an imbalance must be created first and foremost for us to have a pathology, an inflammation. In order for the inflammation to ensue, in order for us to have an inflammatory lesion in our stomach, that seesaw must first be on the side of the gastric acidity and the peptic enzymes, and it must favor that side, and it will only favor that side if and only if there is an increase in the acidity content of the stomach, as someone who drank in a suicide attempt or not acid, so that would increase the acidity, would favor the tug of war in the side of pulling that rope in the side of the offensive, injurious stimuli, and in the duodenal reflex, where some enzymes would leak into the stomach and end up digesting and attacking the protective layer, that protective mucus layer of the stomach. Or we also talked about NSAIDs and how these NSAIDs, we take them to alleviate the pain, but taking them a lot would also deprive us from the good things that prostaglandin does, and which is prostaglandin is very important for bicarbonate secretion, for maintaining the integrity and regenerative capacity of the epithelium, the stomach epithelium. And also we talked about how NSAIDs are important for the actual generation of that mucus layer that protects the core of our stomach, that lines the core of our stomach and protects it from the acid. So no prostaglandin, there will be a diminish in the secretion of that mucus layer. So this lecture only, this a little discussion, if we may say, is just for us to know that there is a constant tussle between forces that try to harm and forces that try to defend. In order for pathology to happen, the forces that try to harm the integrity of that mucus layer must be empowered, and the forces that defend, and we talked about them, must be weakened. So any pathology is caused by a weakening of the defense mechanisms or an increase in the stimuli or in these injurious stimuli. So that's our first step. See you in our next topic. Thank you very much.